Hello and welcome to this session of Maritime Medicine. We'll be discussing allergy and anaphylaxis. By the end of this session, you'll be able to define an allergic reaction, define anaphylaxis, identify findings that suggest anaphylaxis as opposed to just an allergic reaction or other disease process, and list 7 medications that are used to treat anaphylaxis and the doses of those medications when they're used for anaphylaxis. Now, an allergy is an immune system response. So just like we would get if we had an infection or some other foreign invasion, something potentially dangerous to us, the immune system responds. In the case of an allergy, it's responding to something innocuous that's called the allergen. And the allergen is something that's either harmless to us or very minimally harmful. So pollen, for example, really isn't harmful to us. Most people can handle it without a problem, and very few people have an immune system over-response. Bee stings are locally painful, but they're not going to kill you in and of themselves. It's the body's excessive immune response, the anaphylaxis, that kills people after a bee sting. So these are harmless or fairly harmless substances that the body over-responds to. Typically there's a local response, so wherever the exposure is, you get a local response, and possibly also a skin response, hives or other skin changes, and we'll talk more about those. So when you're exposed to an allergen, these cells you have called mast cells, they're the primary effector cells in the allergic reaction. They release a chemical called histamine, and histamine's job is to make it easier for the rest of the immune system to get to wherever the attack is happening. So histamine increases blood flow to that area. It dilates the blood vessels. It makes the blood vessels leaky. It's designed to basically make the immune response much more effective. And it also triggers hives, these raised bumps on the body as part of that. Other humoral mediators of death, that is, other chemicals that get released into the body to promote the immune response, also get released with an allergic response. And between the histamine and these other chemicals, you can get a systemic response, which may be useful or may not be useful. In an allergic reaction, a lot of the symptoms will depend on where the exposure happens, what the local reaction is. So you breathe in pollen, you breathe in cat dander, and you get a runny nose, the eyes begin to itch, you start to sneeze. These are all things that could potentially protect you from an invader. So the mucus, the tears that you make, those actually contain something called lysozymes, chemicals that attack some types of bacteria. The sneezing forcefully pushes these foreign invaders out of your body. But if these aren't things that are going to hurt you, you don't need to do this. So this is a bit of an over-response. If it's cutaneous, a bee sting or poison ivy, or you touch something that you're allergic to, you'll get a local reaction. You may also get hives, and this can happen both with the cutaneous exposure and with an inhalation or an ingestion exposure where you eat something. And so you get these hives, which are raised bumps called urticaria. They're typically 2 to 3 centimeters. They're circular. They're red with white clearing in the center. If you push on them, they blanch. They can join together or coalesce into a large plaque. They can cover very large areas when a bunch are together, and they can be all over the body. You can get what's called angioedema, which is where leaking fluid from the blood vessels causes localized swelling. You can get pruritus, which is itchiness, or you can get just redness. And some people will get redness all over their body without the hives, and that's still an allergic response. It's a histamine response, increasing blood flow to the skin. Now, in a normal allergic reaction, you would typically have normal vital signs. If you don't, then you're starting to think about anaphylaxis. So what's your treatment? Well, the first thing is to remove the trigger if at all possible. If it's goldenrod in the air, that's going to be kind of tricky. You can go inside, you can use filters to protect you. If it's a bee sting and it's from a honeybee where the poison sac and the stinger tear off on the body, you can use something like a tongue depressor or other flat type of stick or something with an edge to slide along the skin and pull the sac out without compressing it, because if you compress it, you push the rest of the toxin into the body, and you don't want to do that. If it's a powder that someone's exposed to, you can wash it off. And then we use antihistamines, because remember, histamine is the main chemical causing the problem. Now, histamine actually affects two different types of receptors, the H1 receptor and the H2 receptor. Those are the ones we care about in allergic reaction. Diphenhydramine or Benadryl blocks the H1 receptor, so it turns off the effects of the histamine on that receptor. But histamine also affects the H2 receptor. And so medications that we normally think about using for upset stomach, like ranitidine, which goes by the brand name of Zantac, is actually a histamine blocker. And so we use that as well as the H1 blocker. So diphenhydramine 25 to 50 milligrams orally every 6 hours. When I'm giving this to someone who's had an allergic reaction but not anaphylaxis, I tell them take it every 6 hours for 3 days and then as needed after that for itching. The H2 blocker, ranitidine 150 milligrams by mouth twice a day for 3 days, then as needed after that. And these control the symptoms of the histamine release. And in an allergic reaction, a simple allergic reaction, that's really what your goal is. If it's an exposure that's going to keep happening, so it's something that's in the air that the patient can't get away from, then you could consider steroids and talk to medical control about this. Prednisone 40 to 60 milligrams orally every day for 7 days may be helpful. And those take hours to kick in, so it's not something they get immediate relief from. But it's something that turns down the immune system for the next week while they're being exposed and can be very helpful. And if the allergic reaction is to poison ivy, give the prednisone for 2 weeks, because if you give it for just a week and you stop, that Rhus toxin, which is the poison ivy toxin, can continue to have its effect, and they get rebound, and they're much worse, much itchier on day 8, and they really don't like you very much. Now, in anaphylaxis, you're getting a systemic response to the allergen. So more than just the skin rash, the histamine is affecting other parts of the body as well. And classically, what happens is you're exposed to something and you don't have a response to it, but the immune system is primed. And then on your second or subsequent exposure, you do have an immune reaction. And it doesn't have to be the second exposure. People can have multiple exposures before they finally have their immune response. So the allergic response is what you see. So typically the skin findings, hives, possibly the swelling, possibly the redness, the angioedema. We typically think of it as hives, but it could be any of the skin responses, plus involvement of the airway, breathing, circulation, or gut. And we'll talk about what those symptoms would look like. So your presentation is somebody who's had an exposure. And this can be very tricky. At times you won't know whether they had an exposure or not. And in fact, you may never find out what the exposure is. But if you have an exposure, that's very helpful in differentiating anaphylaxis from other types of shock. You'll have the dermatologic findings, the flushing, the hives, that localized swelling, the angioedema, itching, warmth, or generalized swelling or edema. Respiratory, you can see nasal congestion. What's much more concerning is throat tightness or chest tightness. If they start to wheeze or have shortness of breath, they cough, or their voice becomes hoarse. The hoarseness is particularly concerning because that suggests to you that the vocal cords are starting to get swelling from angioedema, and that's a real problem. They'll have heart symptoms, cardiovascular symptoms, including dizziness and weakness. They may have chest pain. They may pass out. They may feel their heart racing. Those are all typical anaphylaxis reaction symptoms. Their GI symptoms can include feeling not hungry or not being able to eat, nausea or vomiting. They can get diarrhea or bloating. They can even just have abdominal cramps. But any of those symptoms with the exposure and the skin findings, the allergic findings, are very concerning, or really any two systems. And then neurologically, they can have a headache, they can pass out. Many people have a feeling of impending doom, and that's also very concerning. So your treatment is to identify the anaphylaxis. And so you're looking for a trigger. This can be very hard to distinguish from other causes of shock. So if you have a patient with a low blood pressure and chest pain and flushed wet skin, you're thinking about cardiogenic shock. You're thinking they've had a heart attack. It could be anaphylaxis, but you need to differentiate that heart attack from the anaphylaxis. And having an exposure, knowing that there's something that happened, is really very helpful. So try to remove the trigger and then move into the treatment. So the things you do now before you talk to medical control: oxygen at 15 liters per minute via non-rebreather or bag valve mask, and epinephrine 0.3 up to 0.5 milligrams intramuscular, repeated as needed. And talk to medical control about repeat doses, but get the first dose in now. An EpiPen delivers 0.3 milligrams IM. If you don't have an EpiPen, you use the 1 to 1,000, the small ampules of epinephrine. Draw up your full 1 ml, which is a full 1 milligram, and give 0.3 ml, which is 0.3 milligrams. Then talk to medical control. You're going to use IV fluids if they're in shock, if their blood pressure is low. So a 1 liter bolus repeated as needed. You give them diphenhydramine, either 50 milligrams IV or 50 milligrams IM, and ranitidine, 150 milligrams orally if you have it. Then you want to give them a steroid. If you have an injectable steroid, it could be Decadron, hydrocortisone, or Solumedrol, and those are all the appropriate doses, and they can be given IV or IM. IV is going to have faster effect, obviously, but IM, the absorption's fine, and since it takes a few hours for the steroids to have their effect anyway, the absorption difference is not a big deal. Or you can give them prednisone 60 milligrams orally. If they're wheezing, you want to give them albuterol to help open up the airways, the bronchi that are in spasm. So if you've got nebulizers, it's albuterol 2.5 milligrams and 3 mLs. That's a unit dose. They look like little bullets. You squirt the whole thing into the nebulizer. You give that every 15 minutes times 3. Or an inhaler, and the inhalers typically have 90 or 120 micrograms per activation. It really doesn't matter as long as it's an albuterol inhaler, and it may say Ventolin or something else on. You give 2 puffs every 15 minutes times 3, and then talk to medical control about further dosing. Do you need to evacuate these patients? Maybe. And you need to discuss that with medical control. Reasons why you absolutely would want to evacuate your anaphylaxis patient would be recurrent symptoms. So you've treated them, and the symptoms come back without another exposure. That's called rebound. They need to be evacuated. If you have to give more than 1 epinephrine dose to control the reaction, or more than 2 to 3 liters of IV fluid to resuscitate them to get their blood pressure up, their potential to get sick really quickly again is high. So you need to be able to think about getting them off the boat. And if it's not clear that this was an allergic reaction, so you treated it, they got better, you're not totally sure what happened, anaphylaxis looks a lot like a lot of other really bad things. And so if you're not positive, evacuate them. If they are staying on board, you need to monitor them for at least 3 hours. And that means you stay with them for at least 3 hours after they receive their epinephrine, because they can get rebound when the epinephrine wears off. Sort of a second reaction, looks just like the first, can be just as severe or worse. And typically the epinephrine wears off in an hour to an hour and a half. And so you want to watch and make sure that they don't get worse. And if you have an EpiPen available, give it to them to take with them, because if they get symptoms again, they need to give themselves a second dose. If you don't have an EpiPen available, then you just need to make sure that there's a way of monitoring them, someone keeping an eye on them at all times, or checking in on them regularly to make sure that they don't get worse in the following day or so. Put them on diphenhydramine, 25 to 50 milligrams orally every 6 hours for 3 days, and as needed after that. Ranitidine, 150 milligrams orally twice a day for 3 days, and then as needed after that. And prednisone, 40 to 60 milligrams orally every day for the next 7 days. Please complete any associated knowledge reviews, and if you have any questions, please contact your instructor or professor. Thank you.